My name is Adam Johnell, and I'm going to be talking about anterior compartment syndrome today. So my outline or my objective, what I'm going to be going through, is the definition of anterior compartment syndrome, the anatomy of it, the etiology or causes, some common signs and symptoms, a diagnosing technique, and then treatment, both conservative and surgical, and then the rehab/return to play. So the definition of anterior compartment syndrome is it involves an insult to normal tissue homeostasis within the compartment, which leads to increased tissue pressure, reduced capillary blood flow, local tissue hypoxia, and local tissue necrosis. So the anatomy that is important to this injury is obviously the tibia and fibula. Then the anterior compartment, which you can see is located in between the tibia and fibula, and then the tibia anterior, and then the extensor hallucis longus, extensor digitorum longus, the peroneus tertius, as well as the anterior tibial artery and the deep peroneal nerve. So the etiology and causes, some possible causes are tibial fracture, bleeding disorder, snake venom from snake bites, and then blunt trauma, and then obviously some post-operative swelling. A systematic review done by Shagnon et al. Found that 36% of all anterior compartment syndrome cases are associated with tibial fracture, which makes it the most common. And then the second most common is blunt trauma to soft tissue, which is at 23.2%. And then this same article also found that younger individuals are more likely to have anterior compartment syndrome due to the fact that they have tighter, stronger fascia and are more likely to sustain a serious injury and put themselves in those conditions. So the most common signs and symptoms that are associated with anterior compartment syndrome, obviously pain in the involved extremity, loss of sensation, paresthesia, impaired motor function, tenderness to palpation, and compartment pressure greater than 25/30. Now, right away, you're going to see the pain and then some swelling. The loss of sensation, impaired motor function may not be present right away, but as the pressure inside the compartment increases, they may get loss of sensation and impaired motor function, which can be prevented, as I will talk about later on. So for diagnosis, obviously a history is important. What was their mechanism of injury? Blunt trauma, tibial fracture, snake bite, stuff like that. And then physical examination, obviously they're going to be tense and swollen, weakness, numbness, pain with passive movements. And then the pain is going to be immense. It's going to be really high based on the mechanism of injury that they're presenting. So like with just blunt trauma, you wouldn't suspect their pain to be an 8 or 9 out of 10, but it can be really high. Now, the important part for diagnosing comes with taking compartment pressure measurements. And then the Stryker stick pressure monitor is the most commonly used. It uses an 18-gauge needle, and the downside to it is rather expensive. It's $1,600, and then every time you use it, there is a $66 disposable fee. And then taking the pressure monitor right away is very important for diagnosing anterior compartment syndrome. If you just look at signs and symptoms, you might not suspect anterior compartment syndrome, and then they can get those long-term effects of loss of sensation and loss of motor function. So I have 2 case studies that were done by Harry et al. And done by Hardy et al. And in both of these cases, their patients came in with increased pain and swelling. They didn't have the loss of sensation or motor function right away, so they did not suspect an anterior compartment syndrome. So the physicians just put them on anti-inflammatories and pain control right away, but then both patients started losing muscle function and loss of sensation in the lower extremity. So upon that, the physicians did take compartment pressure measurements with the Stryker stick pressure monitor and determined it was anterior compartment syndrome. But after that, it was too late, and they had necrosis of their tissue and muscles, and then after treatment, they had permanent loss of motor function and sensation, which can be prevented. So the Stryker stick pressure monitor. It is a very reliable technique. A case study done by Julius et al. Compared different methods. There's 3. There was the IV pump and the Stryker were the most common, became to be the most reliable. What they did is they took a slab of meat, of beef, and put it down, and then they put a beaker on top of it and filled it with water to put pressure on the meat. And then they took both the IV pump and striker compression monitor and got the pressure readings and then compared it to the actual pressure that was inside the beaker. Now, with the different varying water levels that they put in the beaker, they found that both the pump and the striker were very reliable in determining pressure monitor or pressures. So to use the striker pressure monitor, what you're going to do is there's going to be the 18 gauge needle, and then there's going to be a diaphragm and then a syringe filled with saline. You're going to connect those three pieces, put it in the monitor, and then push out any excess air that is inside the syringe. And then you're going to put it inside or inject it into the person, and then the striker monitor is going to give you a reading. So for treatment, there is really no conservative treatment once you have diagnosed anterior compartment syndrome, but there are some things you can do to prevent it, which are like stretching exercises, strengthening to get all-around balance in the muscles, working out on soft surfaces, wearing proper footwear, obviously, when working out, and then orthotics can be used to help absorb shock. So for surgical treatment, the gold standard is a fasciotomy, and there is two methods. There's a double incision and a single incision. Now, the double incision is the most commonly used due to the fact that it decompresses the compartments better than the single incision all around. So with the double incision, what they're going to do is they're going to make an incision midway between the tibia and the fibular head, about 5 centimeters below it, and it's going to go the length of the anterior compartment all the way down to 5 centimeters above the lateral epicondyle. And then they're going to make a posterior medial incision, which is going to be medial to the tibia, and it's going to run the length of the tibia. Now, on average, the single incision takes about 8 weeks for recovery through a whole rehab program, and then a double incision is going to take 12 weeks. After they make the incision, what they're going to do is they're going to cover the incision with artificial skin, which is see-through, so they can monitor the swelling and the pressures in the compartments. And what they're going to do with the skin flaps is they're going to use a band, and they're going to weave it like a shoelace all the way up that keep constant traction on the incision, so that as the pressure goes down, the skin keeps coming closer, which is going to prevent the need for a skin graft later on. So for rehab, the first two phases for rehab of anterior compartment syndrome do not go off of week-by-week basis. They go off of whether the patient is weight-bearing or non-weight-bearing in their pain tolerance. So in phase one, right away, the patient's going to be in an immense amount of pain. So they're going to be either non-weight-bearing or partial weight-bearing. So right away, you can start them on some resistive band exercises, and then you do massage for tissue mobility, and then obviously scar management so the scar does not adhere down. And then phase two starts once they become fully weight-bearing. So with that, you can continue your band exercises, and then you do some weight-bearing close connect chain exercises with them, and then obviously gait training, because these patients are going to have some deficits in their gait right away. And then phase three does usually start around 4 to 6 weeks after surgery. And then you're going to be starting on the treadmill and like stair climber exercises and running. So right away, what you're going to be doing is light jogging as the first speed, and they can only run up to 0.5 miles as its max. And then you're going to increase them to eventually 2 to 3 miles of light jogging, and then once that, then they can go up to slow running. Now, phase four starts once they've gone through slow running all the way up to 2 to 3 miles pain-free, and their gait is normal. Then they go to fast running, and you start them with hill running, and they start off again fast running at 0.5 miles, and then increase them all the way to 2 to 3 miles. And then once they are able to fast run, and you've shown, and the physician can see that they can run at their normal speeds, pain-free, their gait is fine, then the physician considers them for return to play. So in conclusion, I've gone through the definition of anterior compartment syndrome, the anatomy, etiology, signs and symptoms, the diagnosis, treatment, conservative and surgical, and then rehabilitation. Any questions?